Hi, I'm Mike Brennan. I'm an orthopedic trauma surgeon at a level 1 institution, here just to kind of demonstrate a basic pelvis frame that you would apply both in the supraacetabular region as well as the iliac crest region in a damage control orthopedic setting. So now we're going to demonstrate for you kind of a damage control orthopedic pelvis frame. With these, we have two of the more common frame types would be those that are placed within the iliac crest and along the brim of this region versus a supraacetabular pin. So we'll show you both of those models today. With those, you can use a single pin, you can use a dual pin construct, and even 3-pin construct depending on the severity of this or the displacement of this region. And so when you're trying to identify where you place these pins, it can be challenging when you have a pelvis that sits externally rotated, very similar to this, or maybe out of the position. And so you may find that you're doing this the simpler side, if you will, initially. You may have hands in there to help internally rotate this side, or you may bring your x-ray beam in to see exactly what level you need to be to place these pins appropriately. And so typically what I would tell you is if you have an uninjured side, you might want to consider starting with that side first. It'll be simpler. So I'm going to turn this around so you can see the region we're looking for. Here we have the ASIS, the anterior inferior AIS, and then we can see here the gluteal pillar. This is one of the regions that's going to be the thickest area of bone, and the more likely for you to be the more likely you are to have the ability to maintain the pins within the bone, as this can be very thin as we get posterior to that pillar. And so you can use 5mm pins, you can use 6mm pins. I typically will use a smaller of those two and use a 5mm pin. Some of the techniques that you can use if you're having a hard time to identify where you are is you can place a K-wire down the internal aspect of the pelvis on that brim and externally to kind of get an idea of what your angle may be. And so typically you'll be approximately 3 to 4 finger breadths back, as you can see here, from the ASIS into the gluteal pillar region. And so here you can do this through a smaller incision or bigger incision so that you can see what you're doing, and that's okay. Typically if you're going to err, you want the pins to be coming out just on the inferior or the internal surface of this more than external, because again, in this model, as I'll show you here shortly, and these pins can go a fairly decent way within the brim. And so here we've maintained this corridor, as you can see here, contained within the pelvis here. Again, to bring back the point earlier, this pelvis is sitting here, so the frame is ultimately going to want to internally rotate this. And so if my pin is out on the lateral surface, as I go to rotate, that pin may fracture through this. However, if I go in here, out, and on this table, it may be rigid enough to maintain that. So the error is going to be on the slightly internal side. However, if at all possible, we want to maintain this bony corridor just like you see here. So now we'll do a similar construct on the other side. And again, this side is always going to be more challenging because it's the more unstable of the two. And again, we're going to go about 4 finger breadths back where we are. I'm trying to maintain within this gluteal pillar, if you will. And so here you have a basic frame, so to speak, if you will. You can simply add other constructs to this. If you feel like you need a little bit more flexibility from the soft tissue standpoint, you can add the pin clamp to this also. So very simplistic frame as you're doing this. I typically will use 2 pins, especially if I feel like one is an inadvertent pin that's not placed appropriately. However, if it's something like these pins that are placed here, it can be as simple as this frame that you're seeing here. Again, the body habitus will dictate a lot of what your pin to bar constructs may be, and so occasionally you may have to have some pins that go out initially and then across, because we may have a protuberant belly that precludes a simple straight frame. However, if the patient is not very big, and it can be a simple frame coming through, as you see here, that just meets simply in the middle once we've reduced this. We want to consider the aspect that the general surgeons may need to be performing a procedure. Urology may be performing a procedure as well, and so if we can bring this frame and construct down even farther out of their field, then we would do so as well. And so now we've got a very simple frame. Okay. Now if the patient is large, and we need to utilize other means to get this off the skin into a more rigid construct, and that's fairly straightforward. So again, another very basic pelvic construct from this standpoint. We can supplement it with additional pins in this region as well. It can be a very simple construct from a pin to bar standpoint as well when you're looking at this overall. This, if it's in the way of your general surgeons, we can simply just drop this frame down and adjust it accordingly, just like that. And so that now, if they need to get down low within the belly, to do any type of retroperitoneal packing or any type of bladder examination or repair, now we can just drop the frame down just like that. And now you're looking at this frame, very simple construct, very straightforward for the most part. And so now we're going to be talking about the supraacetabular pins that are going to go within the AIS towards the PSIS region. So this is the exact range that we're going to be going to with this pin. And so ideally, this pin is going to go here and go towards the PSIS region. Okay, and so you'll start with a rollover X-ray outlet view, so we can see this corridor that will look maybe like a little TP right above this. And so that'll give you the corridor of bone that this should be going to. You'll also want to look at an iliac oblique view to know that this is not going within the notch. Depending on the stability, you may want this for patient comfort. However, the more rigid frame is going to go back towards the PSIS region. And so that's our goal with this next frame, to show it kind of somewhat quick. And again, the affected side can be challenging once again because it's externally rotated, and so it may be a little bit harder to get that X-ray than you anticipate. So make sure that you have a good C-arm and an X-ray tech within there to help you identify this. And you can adjust this accordingly. I can come up a little bit higher to allow the pin to be out of the position from a seated position if this is going to be a more long-term frame. But if it's purely a damage control type of frame, this is pretty much this is the easiest way to maintain it. So here we have the frame, fairly straightforward. We can adjust the pins, come closer down. Again, depending on the body habitus, the anterior thigh, as we're looking at this. And so here we'd have the frame. We would help try to reduce this by utilizing these pins. They can help us quite a bit as we're doing this. As we know, based on all the research and studies out there, that these pins are not going to help control the back as much as they are going to help control the front of the pelvis. So here's a quick basic frame in the supraacetabular region. Again, pretty straightforward within that corridor of bone right there that you see. So pretty straightforward overall, and it gets, as you can see, out of everybody's way from all the way up. So this is a pretty basic frame. Quick damage control frame for the pelvis.